everybody. It gives me a great honor to be able to introduce you all to our first webinar um, uh, against, where we were together against COVID-19, 4 years strong. So I just want to quickly give you a bit of an overview. It's December 31st, 2019. The World WHO China was informed of cases of pneumonia of unknown etiology. Yet it wasn't until March the 11th, 2020, the World Health Organization, International World Health Organization, declared COVID-19 a viral disease, a pandemic. And I, on behalf of Workplace Health Without Borders, this was kind of leading up to the coalition. A letter was provided to the Minister of Health and also the chief officer for the PHAC as well, and I'll put that in the chat box. Then recently, a while ago, on May the 4th, 2023, the International Health Regulation Emergency Committee of WHO actually downgraded the COVID pandemic. So, since the whole pandemic started, thinking about China invoking airborne precautions, a number of us have come together and formed the Canadian Aerosol Transmission Coalition, who's been spearheaded by Alec Farquhar. Alec's going to be talking shortly. So it's the fourth anniversary of the pandemic, March the 11th, and the speakers that we have to talk to you today, I've got them listed there. I'm actually going to introduce you to the first section, the back and forth of modelling, and also national opportunities to make a difference. And then I'm going to hand you over to Dorothy Wigmore, who's going to talk about snapshots from the grassroots, including a number of speakers there. And then we want to talk about how do we make more progress. I just want to tell everybody about this really great book that is now available. It's called Breaking Canadians. And many people in the coalition, or there's a number of people in the coalition that have actually written chapters in this book. So I highly recommend it. It's really good to hear the story from the different people that have contributed to it. And it's also wonderful to see the way the coalition has kind of snowballed. And I really want to just take my hat off to both Alec Farquhar and Stefan Belladou, who co-chaired the coalition, has been relentless in carrying on, keeping the coalition and broadening the coalition. So now I'm just going to hand it over to the first speaker, although I'm not sure. We are waiting for Dr. Tara Moriarty.
She's here, Kevin.
Okay, so Dr. Tara Moriarty is from the University of Toronto. She has COVID Resources Canada. She's talking about using available data to estimate COVID infection rates and excess deaths. Over to you, Dr. Moriarty. Thank you so much.
Thank you, Kevin, and thank you to all the organizers. And my apologies, Valerie and everyone, for any heart attacks that I may have given you. I had a CIHR grant due last week, and I'm pretty overwhelmed and burnt out. So I'm progressively having trouble staying on top of pretty much everything, but except modeling. So if I could, do I have screen share abilities?
Yes, you do.
Thank you very much. Okay, I'm just going to give you a snapshot from a paper that I'm working on right now, which is actually looking at how Canada has reported and how Canada has reported and what we can tell about what is still going on. So most of you know that a group of us, including quite a number of people who are here right now, volunteers and citizen scientists, do a regular COVID forecast. We didn't have one this past weekend because of my grant deadline and because I'm in the middle of updating the model, but we will have it this coming weekend. But what I wanted to show you was a summary of what we've been looking at in terms of the impacts of COVID-19 in Canada since the beginning of the pandemic. And I'm just going to zoom in a bit and try to get rid of my Zoom bar. Okay. And I'm going to zoom in a little bit more and move this over. This is just my graphing program. Okay. All right. So these graphs provide an overview of deaths and non-incidental or from COVID hospital admissions from February 2020 to December 2023. And we assemble this information from a lot of different sources. It's quite challenging to do. But for deaths, we get excess mortality from Statistics Canada, and we correct to remove deaths that are excess deaths that are attributable to toxic drugs, to heat waves, to delayed healthcare, for example, and MAID, which we look at by excess deaths attributable to cancer. And the remainder is what you see plotted here. So the excess deaths are shown in blue. These are these blue waves here, and I'll explain this part in a moment. And reporting is still quite incomplete for Canada. So we don't really know. We don't have full reporting yet past the end of 2021. Actually, we're still seeing deaths coming in from the first Omicron wave. And you can see the deaths that have been reported by provinces to the Public Health Agency of Canada in red. And you can see that over time, although reporting was initially quite good early on in the pandemic, there are reporting delays. So, for example, a lot of these deaths haven't showed up in the Canadian Vital Statistics death database. So there are peaks here that may represent deaths where we don't actually know the date of death yet, but may correspond to this region in here. But you could see that over time, reporting of COVID deaths has declined really dramatically in Canada, to the point where we're probably only seeing at best 25% of excess from COVID deaths. So these are people who would not ordinarily have died of other causes. And when we look at non-incidental hospital admissions, we look at hospital admissions reported by provinces. We look at hospital admissions reported in the PHAC case data set. There are a whole bunch of places, including the World Health Organization, because in some cases, Canada has reported more hospitalizations to the World Health Organization than are currently reported in our national data. And we look at information from the Canadian Institute for Health Research or health information. And we estimate, based on the percentage of people that we estimate were infected at the time, how many of these hospital admissions could truly have been from COVID. And we subtract the ones that epidemiologically are likely to be likely to be incidental. So that would be with COVID. And in this graph here, you can see the reported hospitalizations in red at the front. These are the admissions reported to PHAC. And in blue are the hospitalizations from all sources. And then we can also calculate from this and from the duration of hospital admissions from PHAC and CIHI, we can estimate what percentage of hospital beds are occupied by people with non-incidental or from COVID hospital admissions. And you can see that, for example, in the very large wave that we just had, more than 30% of hospital beds would have been occupied by people who had COVID-19. Then what we also do is we estimate how many of these deaths could have been prevented if people were getting vaccinated every 6 months. And in this figure here in gray, This is the percentage of the population 40 and older in Canada that was protected from severe outcomes. So that would be hospitalizations and deaths from COVID-19 were protected by vaccination. And protection against vaccination wanes over time, but also we've seen a huge drop-off in vaccination rates. So you can see that by 2023, for example, less than 10% of people 40 and older were protected from severe outcomes by by vaccines in the summer, and then that climbed a bit to 20% by December of 2023. So using this information, we can estimate what proportion of deaths in this case were preventable by vaccines, but were not prevented. So these were the deaths that were not averted. And for the pandemic to date, we're looking at about 69,000 excess deaths that could have been prevented by vaccination, but were not. And that's 7.1% excess mortality for those who are interested. The other thing is that the percentage of people, I'm going to zoom in a bit, the percentage of people who were vaccine protected is very strongly correlated with the percentage of deaths that are reported. So as death reporting declined, the percentage of people who were getting regular vaccine updates also declined, and this is a very strong correlation. And when we look at hospitalizations the same way, you can see that the vaccine preventable outcomes that were not prevented because we were not administering vaccines or advising people to get vaccines every 6 months. There have been about over 300,000 hospitalizations that could have been prevented, $7.3 billion in hospitalization costs, and we could have liberated 5.5% of hospital bed capacity, which doesn't seem like a lot, but it makes an enormous difference when the system is really overloaded like it is. We can also estimate from this the number of beds that were not available to people who didn't have COVID-19, but who needed hospital bed for another reason. And there are about 648,000 people in this period who could not access hospital care because of beds that were occupied by people with COVID-19. So overall, there have been, up to 2023, there have been about 120,000 excess deaths in Canada since the beginning of the pandemic, excess deaths that are related to COVID. And there have been a total of over 500,000 hospital admissions. And we're actually revising some of these numbers upward because we have identified some other sources of information. And the costs of hospitalization over the entire pandemic have been about $12.2 billion. About 9% of hospital beds have been occupied at any given time by people with COVID-19. And there have been over 1 million people who couldn't access hospital care requiring a hospital bed because of beds that were occupied by COVID-19 patients. And then finally, I want to draw your attention to 2023. And there is a period, without doubt, where we had lower infections and hospitalizations, but we just came out of a very large wave. And I'm just going to share with you, I'm just going to share with you a model. I'm just calibrating it right now, so it's not quite ready. But I just wanted to show you, you want to look at the pink line here, and the pink line is the model of the number of infections. This is for the Omicron period, so from the start of Omicron to present. And you can see that we've just come out of really one of the largest waves of the pandemic to date. And we are definitely infections are definitely declining, but we're seeing stabilization in wastewater levels again in most provinces. So the decline looks like it's ended, and I think we're probably going to be entering into a period where we see a slow decline until about July, and then we may start seeing a steady climb again, which is not unusual. We sort of come down to lower levels around July 1st, sometimes a little bit later, and then climb again through the fall and winter. This process repeats, sometimes with a wave in the spring. So based on what we're seeing with excess mortality, this period here is we have to estimate what the excess deaths will be based on the excess mortality to reported COVID deaths ratio. I don't think it's going to be quite this high, and it'll be distributed. But you can see that certainly in 2023, we're seeing and the reporting is incomplete. So I think that we're seeing maybe a little bit less excess mortality than we did in 2022. But overall, it's not a huge decline, and it's clearly worse than we were still seeing from 2021 to early 2022. So there are still a lot of reasons for concern and a lot of reasons for action by this group and others. And we really do need to be reaching people and helping people understand that they need to prevent being infected, and also that would be by masking, but that they also really need to be keeping their vaccines up to date, since we're obviously not using this sort of one remaining barrier that that we still use, or at least advocate for more routinely at an official level, but we're really not using it enough. And despite the fact that probably close to 100% of the Canadian population was infected by the end of 2022, we're still seeing very high rates of excess mortality. So that's it. And it's not, super encouraging, but it means that advocacy is extremely important.
Thanks so much, Dr. Moriarty. I think it'd probably be good now, just for the time's sake, and we really we know how busy you are, and it's great that you can kind of share your modeling with us. But I think what we might do now is go to Dr. Gosia Gasperowicz, fondly known as Gosia. She's been, a long time advocate with the coalition, but she also brings science to the table as well. And I don't know, Dr. Moriarty, whether you can stay around for a little while if there's any questions after this first
Oh,
session.
absolutely. Yeah, no, I'm going to stay for the duration of the seminar.
Wonderful. That's perfect. Thank you so much. Okay, then, over to you, Gosia. So Gosia is from the University of Calgary, and she's talking about predicting infection waves and now long COVID trends. So thanks again. Over to you, Gosia.
Thank you very much for a kind introduction. Hello, everyone. So I would like to share my screen. And I will talk today about the projections and how we can predict the future, or some aspects of the future, about the past predictions of the waves and not only. And I would like to share with you the projections of long COVID for summer 2026. So So since thousands of years, we use science to predict the future. And we do it by understanding of the figuring out how things work, so understanding the mechanisms of a phenomenon, and we use it by observation, measurements, and applying logic. And on basis of this understanding, we build either a mental model or a mathematical model of the physical phenomena, or describe it with mathematical equation. Then we can feed the parameters or data points into the model and get the prediction of future or the consequences. And we use it really for thousands of years. So, for example, discovery or creating the agriculture is based on science and predictions. We know when to plow, when to seed plants, and so on. Rocket science is, of course, science. And so we know in what we can predict. If we shoot a rocket in a slow speed, it will land somewhere on Earth, and we can predict where it will land. If we shot it faster, we can reach the moon, and we exactly know what speed we need to use to achieve each outcome. And also some banal things like planning our travel. Like we use science for this. We use model to calculate how long time it will most probably take us to drive from Calgary to Banff. And we know that in 20 minutes, it's just physically impossible. And the most possible is probably 1.5 to 2 hours. So science is used everywhere, models we use everywhere, and we predict future all the time, basically. So what math models predicted, or mine and also other people could predict in the past during this pandemic, and most of the predictions actually came true. So I predicted first, second, third, fourth, and first 2 Omicron waves. We could predict when to achieve zero community transmission, and in regions when they aimed for zero community transmission, actually it was achieved. It was predictable that the vaccines alone, like the first 2 doses alone, especially when we had Alpha and Delta variants, won't be able to end the pandemic. That to stop the pandemic, we would need to have both vaccines and non-pharmaceutical interventions. And it was a very simple equation, actually. And that so-called mild Omicron will kill a lot of people. So all those predictions came true. And then I will talk also about the future predictions, but first, I will show some examples. So here's example of predicting variant wave, alpha variant wave, so called UK variant wave in Alberta. And actually just based on the understanding of the mechanism, so that the spread is exponential, and having some basic parameters of alpha variants, already in January 2021, it was possible to predict the RAF curve or RAF exponential curve of the alpha variant. And it was pretty clear that if we don't put some extra protections in place, then we will have the wave. It wasn't clear exactly when it will be here or more in the future, but the fact that it will be here was almost like, it was pretty clear. And then once we had more data, so all those red points are alpha strain, like amount of cases reported in Alberta of this new variant. And we can see that it followed the theoretical exponential growth curve. And by extrapolating this curve, we could again predict the shape of the fact that there will be alpha wave and the shape of it. And the fact that it will be if we do nothing, right? And we did nothing, and we actually did some reopenings here, and the reality confirmed the prediction. So we had alpha wave. Here, protections, public health protections were introduced, including school closures, and that broke the wave. The same pattern was with Delta wave, so it was already predictable in end of May 2021, when we knew the parameters of Delta, and we knew, of course, that it's exponential growth. Then when we had, with the numbers, with the observed data, again, we had the similar prediction of Delta wave, and then we had reopening starting in May 26, then open for summer in the beginning of summer in Alberta. And then we had like real growth. So the reality basically confirmed the predictions. And what happened here was interesting. So for 2 weeks, and that's how important the advocacy is. So for 2 weeks in summer, we created Protect Our Province, Alberta, and for 2 weeks we protested. We had rallies on the streets, and at the effect of it, Chief Medical Officer of Health reintroduced protections like test, trace, and isolate, like very basic ones. And finally, it broke the wave. And what is important, our Delta wave was totally predictable already in May, even more predictable in June. And it was 3 times more deadly per capita than Delta wave in Ontario. Okay, so we can predict the waves, the exponential growth, but we can also predict exponential decline and how fast it will decline. So here I predicted that Victoria, Australia, so Melbourne and Victoria State, will reach 0 cases in the big second wave on October 13th, 2020. They reached it on October 26th. So, okay, I was 2 weeks off, but what they did, they had gradual reopening, which slowed down the speed of the decline. And what was really very special in Victoria is that they designed reopening with modelers. So basically real mathematicians, modelers designed the reopening, and they knew when to reopen it safely without the high risk of rebound to another wave. And they succeeded. They have the Donuts Day, so like 2 zeros, no new cases and no new deaths. There is another prediction here that came true. So already in March 2021, one could calculate from a basic equation. So we can please take a screenshot and then maybe read about it. So the percent of reduction in R value equals vaccine efficacy against transmission times percent of population vaccinated. So it's like really simple equation. So already knowing alpha and delta properties, how much more transmissible they are and what their reproduction number is, we knew that it's basically impossible to stop the spread just by 2 doses of the vaccines. And yeah, and it was very, very clear already in March. But we could calculate that actually if we would add some protections, some public health measures on top of the vaccines, then we can really get R value to very, very low levels, even with those more transmissible variants. So it was possible to stop the transmission. And okay, it didn't happen. We've been told that vaccines alone will stop the spread, will end the pandemic, and yeah, they didn't. And please really take the screenshot because it's also very relevant now to measles. And another prediction was about Omicron. When it started appearing in November, December, there were those narratives that Omicron is mild, is a blessing in disguise and natural vaccine. But from also not very complex math, it was clear that the variant that is more transmissible, even if it would be 10 times less lethal, will kill more people than a variant that is 2 times more lethal and slow, because it's exponential growth. And again, the narratives were totally opposite to the math reality. And what happened is actually that Omicron waves, the 3 initial Omicron waves, killed, and there are just not even excess deaths, there are just reported deaths, killed more Canadians than the most deadly second wave. So okay, so we had those predictions that came true, and what about now? So now we are a little bit, the pandemic changed a little bit. So we have, but the only thing that changed for better is that we have less immediate ICU for adults. But as we've seen, like what Professor Tara Moriarty showed, that we have high level of hospitalizations, still high level of immediate deaths, even higher level of delayed deaths, so excess deaths. And what is really now, okay, and ICUs in adults are lower, but we have very high rate. Actually, babies have the highest rate of ICUs among all the age groups. and have one of the highest rate of hospitalizations among all the age groups. Early in the pandemics, babies were not affected. Now they are very, very affected, especially the group under 1 year old. But what is really big now, because of mass infection of everybody and constant reinfections, this lower level of the underwater level of COVID iceberg is huge. It's really large. So we have reinfection, we have COVID effect on home, we have orphanhood, we have sequela, so cardiac events, strokes, blood clots, diabetes, long COVID, which is really large, and we could have still unknown effects. So those are also, many of them are also severe outcomes. And this thing is huge and it's growing. And the question now is how much and how fast this thing will grow. And so we can have some insight about the theoretical in long COVID. So it's like Russian roulette. So the more cumulative risk always increases. The more you play, the more risk of severe outcome. 2 years ago, we didn't know on which of those trajectories we are. What is the risk of long COVID per infection? If it's 1%, it grows. If it's 5%, it grows more. 10% even faster, and 20% even faster, but doesn't matter on what is the risk per particular infection. The thing is that the cumulative risk always grows. And now we have some observed data, so several studies that measured long COVID per infection, cumulative risk per infection, and we can see that they follow the cumulative growth pattern. Some of those, and it's probably above 10% line. And here is the report by Kwang et al. From the last fall, which is a report from Stats Canada. They showed that the cumulative incidence of long-term COVID symptoms increases with the number of infection in Canada. And it was for one reported infection is around 15%, then for two, 25%, and 38% for people who had 3 or more infections. And what is interesting that cumulative the prevalence of long COVID reported by Stats Canada fit perfectly the theoretical cumulative risk line. And it not only for all COVID from all variants, but also from infections from Omicron variant. So infections from Omicron don't cause less long COVID in the future. And so based on this, I could make projections till summer 2026, how much long COVID we will have among adults. And if we continue reinfections at the rate we have them now, and assuming that the severity of infection is the same, so that we won't have some totally super deadly variant coming, then we can expect that in summer 2026, there we have 9 million of adult Canadians who will have at some point, who will experience in some point of time long COVID. 5 million will have long COVID ongoing, some symptoms, and 1.2 million will have severe form of long COVID. So basically disabling that often or always limits their daily activities. And we have just 30 million of adults in Canada. So 9 million is 29%, 18% ongoing long COVID, and 4% of disabling long COVID. Those numbers are really, really large. And so when we just zoom into the purple line, so on disabling long COVID, we can expect 4% of adults having it ongoing in 2026. And 4% is not a small number, it's 1 in 25. So again, the concept, I'm not an economist, but I think like those numbers are really big, like 4% of workforce being affected and disabled and not able to work, 18% of workforce having some limitations, can really affect every system. So even if I won't have long COVID, people around having them can have a big effect. And also, what is not added into this projection is that I didn't include prolonged, like delayed sequela. So like with viral diseases, for example, like with AIDS, with Spanish flu, with polio, we have those delay sequelae that don't manifest until years after it happens. So even if we now would totally stop all the transmission, some growth will be baked in, but we can make it grow much, much less if we prevent transmissions and reinfections. So coming back to this slide, those things were predicted, and they could all be, in the past, in the pandemic, that could all be prevented had we taken preventative actions. Because we didn't take preventative actions, lots of those predictions became reality. So that's prediction for the future, like 18% people with ongoing long COVID symptoms, 4% with disabling symptoms. We know that long COVID affects more the working age group of adults, and I really don't want this to happen. We can really prevent it, but we have to acknowledge that it's a highly possible and do something about it. Thank you very much for your attention, and probably I can take some questions now. Thank you.
Thank you so much, Gosia and Tara. We really appreciate you sharing this really powerful information. It really just brings home how important our work is. And I'll before I put it out questions, I'm just going to ask you both, if you've got a prediction up to 2026, what could you see happening if we predicted out to, say, 2030, for example?
So yeah, it's growing. I have predictions further, but I just wanted to focus on this. They are so so high that nobody would believe in them. And I think 2 years is relatable, because it's like in 2 years from now, we will have summer 2026. I can find the slide with the prediction for the, and show it in a moment.
It just looks frightening to me, like the trajectory is going up and it's 2026, but then what? It's kind of very powerful information. I don't know if you had thoughts on that as well, past 2026.
Yeah, I have, and I will show it in a moment. But then, like, one comment to those predictions is that actually the effect we see now is mostly last 2 years. Like, it's not 4 years, because like till beginning of 2022, only like about 10% of people in Canada were infected with COVID. From beginning of 22, and by spring 2022, majority of Canadians had been infected at least once. So it's like 2 years ago, this mass infection started. So basically, it's mostly the effect of last 2 years of mass infection and then constant reinfections. And already in some countries, like wherever there is economic data, for example, there's data from German, like report just said, like, published in the media, was that in 2023 they could have a growth, but they have slight recession because of how many people were sick. So average worker had 20 days off because of sickness in Germany. It's average, and that put them into recession. So with those smaller numbers that we have of long COVID, we already see the effects. When they double or triple, the effects can even double and triple, that there will be probably even a cascade, right? Because it's like at some moment, probably there's some inflection point when you have 5% or 10% workers unable to work, then the things collapse. I don't know what the number for the collapse is, but it's really worrying.
Thanks so much. Now, you're welcome to, if anybody wants to ask a question in person, please do so. But I see Keith Muse has just asked a question here. Do we have this modelling for every province?
Yes, I have those numbers calculated for every province. I can also pull it out in a moment.
Okay, we're still good for time. And I'm just, we talk about prevention just from both of your perspectives. What do we really need to focus on moving forward?
Well, I think we need to advocate for layers of protection. I think from my point of view, because I think a lot about the the severe outcome or the deaths and hospitalizations and hospital capacity issue. I really think we need to move to a model where people are vaccinated every 6 months, and that we need to have really sustained communication about that and campaigns. So if people are people who are higher risk, certainly if people 40 and older, or with underlying health conditions. And if we do that, based on all the evidence that's out there, even for Omicron, we likely could prevent about 75% of severe outcomes. So in 2023, for example, 2023 remained very bad. But a lot of it was because we had such poor vaccine protection. About 75% of the deaths, the approximately 40-something thousand deaths in 2023, could have been prevented with regular vaccination. Same thing for the hospitalizations. And then on top of that, you also want to have the other layers as well. But even with the one tool that we're willing to use, we're really badly underusing it.
Thanks so much, Tara.
I did actually want to also say just very quickly, I just want to show you, I just want to share screen and show you ICU admissions. ICU admissions are actually extremely underreported. And the graph that I'm showing here is ICU admissions from all sources for Canada during the epidemic and the ones that are reported.
So I
so you can see the ones reported. Oh, sorry.
It's not coming up, Tara.
Can you see yet?
We've got a black screen. Oh, here we go. Yes, we see it now. Thanks.
Okay. So I just wanted you to give you a general impression. The red is the ICU admissions reported to PHAC, and the blue is the actual ICU admissions from all sources. So you can see that, certainly the spring 2021 wave was terrible. And a big part of that was because it was terrible in Ontario, which is Canada's largest province. But you can see that ICU admissions actually remain really stubbornly high, but we're really just reporting only a very small fraction of them. So I just wanted to share that.
Important information. Thank you. So we've got a couple of minutes because we wanted to kind of wrap this session up at 1:45.
Kevin, there were some questions in the chat from Megan Eade, and she had several questions. So Megan, I don't know if you can unmute and ask your questions.
Thanks, Mary.
You're welcome to, or I could find your questions.
Hi, so sorry, I don't really have questions. I am just absorbing all this data and sometimes making random comments. Thank you so much.
Oh, okay. All right.
Tracy Cassavant did have a question, though.
Tracy, you can unmute and ask if you want.
Sorry, I thought you were going to read it out. Yeah, I'm really curious about the differences between the external models and the internal modeling. And I'm having trouble not attributing it all to nefarious purposes. But I mean, I know that these are to some extent your colleagues, and what do you know about what's going on in terms of assumptions that are being made, and what are the good reasons for why some of this has been called so wrongly?
Well, partly, I think that, so even assuming that there were very regular communication about COVID by official spokespeople, I do think that a lot of people have tuned out, and some people it wouldn't necessarily get through. And I think we need to have extremely creative advertising and communication campaigns to reach people. So for example, COVID right now is killing the same number of people every year in Canada as smoking, which is a lot. COVID is killing more people per year, at least it did in 2023, than in all of World War II for Canada, for Canadian deaths in World War II. So I think we need to think about this creatively. It's still the number 3 cause of death. It's still the number 2 cause of hospitalization, even in 2023. I think that there is genuinely, I think that the data are so bad and that there is so little official public modeling that I think a lot of people genuinely, it takes so much work to piece all of this together to try to understand what's actually happening, that I think people simply don't have time, and that they will have a quick glance at data and that's what they're seeing, right? They're not, it takes enormous amount of stitching things together from all kinds of different places to understand what's happening. And then also we have an issue within provinces which is that provinces are pretty insular and people talk within provinces, but not to each other. So they don't look at, for example, so BC actually is the best ICU reporter in the country, but other provinces don't look at BC's ICU admissions and say, why are our reported numbers so different? Quebec is good for reporting hospitalizations, etc. So I think that these are systemic problems and they're a problem of culture, and these are long-standing problems. And I do know quite a few people who are, good faith, trying to do something about it. But without data, it's very challenging to move ahead and to make a difference. And that's a big part of why we do what we do, so that there are some data out there.
Thanks very much, Tara. I just noticed in the chat box too, Mary Jo Avers has said, Ontario school safety has a lot of ideas, but not enough resources to help educate the general public. Would appreciate any support or any suggestions on how to manage this great need. So I think it's probably time to move on just to our next session. Really appreciate you being here and just providing this really powerful information. Dr. Joe Vipond's going to join us, I think, between 1:50 and 2, so we may have to be a bit flexible and let Joe talk about his work too. But so what I might do now is hand you all over to Alec. So over to you, Alec. So Alec's going to talk about the ways forward.
Oh, it is me. Great. Hello, everybody. What a great turnout, and to see so many familiar faces and also some new people. That's always really great. It's been quite a time. I'll introduce myself very briefly, and then I've got just a few slides on a little bit of where we've been and where we hope to get to in the next period of time. I'm Alec Farquhar, and I was hired in 2005 by the Ontario Ministry of Labour to play a major role in implementing the Archie Campbell Commission recommendations after SARS. So just like now, we learned some terrible lessons, albeit on a much smaller scale. And there was a lot of political support to make some big changes. I was very fortunate to have that kind of support. And we did a lot. We implemented proactive inspections of long-term care homes in Ontario. We implemented the precautionary principle, which meant protection against airborne transmission as the sort of starting point until it was definitively proven that a virus was not transmitted airborne. And a little later on, we implemented the strategic stockpile for PPE. And as you'll see in my presentation, these were all great ideas, and for various reasons, they were abandoned, primarily. Budget reasons, political, ideological reasons, etc. So when COVID came along, we were not ready. We're not nearly as ready as we could have been. And thousands of lives were lost. And our job out of this meeting and other similar ones is not to forget how bad it was, not to forget the needless lives that were essentially disposed of, the terrible scenes that we saw, military going into long-term care homes, for heaven's sakes, in our country, which so many people would like to forget from a, we'll say, a negative point of view. And unfortunately, so many political people want us to forget. So I'll very briefly, I'll share my screen, and hopefully in a very short turnaround, we will, I think what I better do is, if I can pull it up here, there we go. Now, is this working? I think it is.
Yes.
Yes.
And here we go. So here we are. It's been 4 years. It's been really tough. And this has been a great group to work with. I thought I'd start with very, very briefly, some lessons from SARS. It's a long time ago. Some of you probably weren't involved in issues like this at that time. And I thought, let's look at some lessons we learned. The voices and stories from victims were very important. In other words, not just scientific arguments, data arguments, but people's faces. We had the Campbell Commission, unbelievably independent and well-resourced. That was a major focus in Ontario, but really for the rest of the country. We had healthcare unions collaborating. We had the labor movement very engaged. And a comprehensive strategy came forward, and a lot of changes were made, and I've just summarized some of them. That included legislative amendments in Ontario that gave the Occupational Health and Safety Act primacy over public health directives, so we could go further than public health was willing to go. And that was because Archie Campbell did not want the Ministry of Labour ever again sidelined in protecting workers. We really believed in regulatory enforcement. In other words, not just having guidance, but enforcing it. And we believed in involving the workplace parties. That included something that happened on my watch, which was the creation of a Ministry of Labour healthcare program with its own Section 21 committee, which was an employer labor committee where a lot of good things have been done together. And as I mentioned, we implemented proactive inspections of long-term care. And I will tell people on this call, especially the private owners, did not like those proactive inspections. They didn't like being told to fix their HVAC systems and maintain them properly. They didn't like to be told to make sure that they had up-to-date pandemic and infectious disease response plans. This was all expensive, and it took away from their bottom line. So unfortunately, that was essentially abandoned in 2018 in Ontario, although restored to some extent later on as things got so terrible. I mentioned the stockpiles. They were so important. 55 million N95 respirators were in those stockpiles, but I guess it was too expensive to maintain them, so they were essentially abandoned. Ironically, the last landfilling of N95s happened in December of 2019, just in time for the arrival of COVID. Public health policies I mentioned were changed to incorporate the precautionary principle, especially airborne precautions. And of course, that all eroded away. And at the same time, we offshored our supply of manufacturing for PPE, which turned out to be a terrible policy decision. I mentioned lessons from SARS. Well, here's some lessons from COVID so far, 4 years in. The stories have still been very important, although many want to forget them. The stories of families who lost loved ones, of people who barely survived in long-term care, some of the horror stories and images that emerged from that, and then the broader picture that we've seen outlined by Gosia in particular here of long COVID and what that means to hundreds of thousands of Canadians. We had collaboration by unions across the country, including strong legal and mobilization strategies. And of course, we're here today because of collaboration with public and occupational health professionals, especially CATC. And we gave the labor and community activists scientific backing for improving prevention measures such as ventilation, air purification, and respiratory protection. Some more lessons. Major alliances were formed with parents and families. Right on this call, we've got on the OSS, which is essentially a parent group fighting for better air quality in schools. Those kinds of collaborations can be very powerful. We got a lot of supportive media coverage for airborne transmission. We even had briefing sessions for the media. Some of them brought us into contact with journalists that we're still in contact with today, 4 years later. I think our first media briefing session was in March of 2020, if I'm not wrong. Social media, they can help give a voice that wasn't there after SARS for sort of creating a space for conversation. And I think on the call, we've got Joe Vipond, what a master of social media, and we've got other masters of social media in our group here today. Well, what have the results been? I'm calling them mixed. Some have been discouraging, obviously. I think some of Canada's success did come from courageous decisions to do things like close schools, shift to remote learning. It wasn't easy on a policy level. It was attacked by many forces. A lot of people accept airborne transmission, so we've had some improvements in ventilation and air purification, including in many schools. But as everybody in this call knows, the forces ranged against workers in the community have been very strong and stubborn. They've been reinforced by extensive misinformation and active anti-science campaigns. And again, as we well know, some of them supported by important political groups, even elected officials, even premiers of provinces. So we're ranged against powerful forces and well beyond Canada, of course, too. So putting all the lessons into focus. For the next phase, stories. We can't just base what we're saying on the data and science, strong though it may be. We can continue to use, as we did in the asbestos struggle, which I was very involved with, to ban asbestos in Canada, the international impact, which has often been worse than in Canada and continues that way in some situations. In terms of the unions, we've had tremendous support, and ideally we'll have the whole labor movement behind whatever we do. And we've had just tremendous engagement with the labor movement around the CATC policy development process. Links with community activists. A lot of you are involved in that on that level, sometimes in isolated small groups where it's really easy to become discouraged. And one thing CATC in this very webinar we're striving to do is bring you together, show you you're not alone, show you that lots of people are thinking your way. It's just that we aren't getting very much publicity. And so that means that victims and families can play a crucial role and should continue to do so. I'm mentioning journalists and filmmakers next. For things like the asbestos struggle, the long-term support of journalists and filmmakers, other creative people, has been very important. Maybe we'll see some good documentaries. Public health officials, health researchers, and health professionals. I want to stop for a moment on this. I vividly remember a couple of months after March of 2020, a famous letter in the Toronto Star accusing some of those on this call, including me, of being conspiracy mongers and theorists. And there were signatures on that letter, one I'm thinking of in particular, of people who later changed their mind and came around to the view of the science that we were taking. So I'm a real believer in never giving up on dialogue, never giving up on the belief that people will act in good faith and based on science. So there are lots of people we keep talking to, and every once in a while, somebody sort of, I guess, switches sides and comes our way. And we've got to continue that, sort of a big tent type of approach. Angry as we sometimes may get at some public health folks who seem to be ignoring science. So for the asbestos issue, the relationship building over the long term with the media, public health, et cetera, was really important. We'll keep doing that. A big tent is really important. We can't be seen as a sort of small group of science nerds and that no one will listen to. So I'm giving an example here of education and healthcare unions linking with organizations advocating for seniors around structural reforms for long-term care. Things like ventilation, air purification, which remain vital for schools. So sort of weaving together forces who may not always be working together. I've got a few slides here, which I'll go through literally in seconds. And these are the outline of framework for a robust pandemic preparedness strategy. This is familiar territory, I'd say, for almost everyone on this call. We need institutions that are much more reflective of all the voices that need to be heard. We need a stronger capacity for research and innovation. We need an interdisciplinary approach. Physicians do have a lot to offer, but so do a lot of other disciplines, and I list some of them here. We need transparency, accountability, and reporting. Data and early warning systems. We've got Tara on this call, Gosia. They're substituting in a way for something that should be just a natural part of our institutions. Robust data that just keeps on informing decision-making. And of course, we haven't always had that. In fact, we've rarely had it through this process. We've had data suppressed. We've had data misrepresented. We've had data deep-sixed. Restoration of the precautionary principle. A lot of work is being done on that now. Changes to our built environment, regulatory enforcement, the supply chain issues. What a mess, and it's still a mess. We've got a lot of work to do. Stockpiles, we've got to rebuild them. And all these supports for workers. If people don't have sick days, they're going to come to work sick. And we faced that during COVID. Finishing off, I think. A couple more slides on this. Moving forward to make change. We believe in CATC that there's a potential for a broad and impactful coalition of civil society organizations and individuals to win positive changes. So that's the labor movement, disability organizations, other vulnerable populations such as people with health conditions, Indigenous organizations, equity-seeking groups, professional organizations. You start mobilizing all of these together, we can make a lot of progress. And we have formed 5 working groups. I've listed them here. I think we'll share the PowerPoint afterwards so you can have this information. But you can get involved. The working groups are striving to come up with the best proposals possible. And let's wish ourselves the best of luck. We've been strong. We'll stay strong, and we're going to move forward, and we're going to change this framework for the better. Thank you.
Thanks, Alec, and just thank you so much for being the glue that's brought everybody together. We really appreciate it. I see that Dr. Joe Vipond gave about a 10-minute window. He must be very busy, so I might just hand it over to Joe. I did provide a link to the Canadian COVID Society in the chat box. Joe might want to talk about that as well. Over to you, Joe. Thanks so much.
Well, I'm a little intimidated after those nice slides. I have no slides. I just have words and anger sometimes. My name's Joe Vipond. I'm an emerge doc in Calgary, Alberta. I got involved very early, kind of by accident. I kept hearing things that by people who were guiding our policies, saying stuff like, there's no asymptomatic spread, there's no nosocomial spread, we don't have to wear masks in hospitals. And I was like, I have no background in this, but just having done some reading around the Diamond Princess and around what was going on in Wuhan, I'm like, these are objectively not accurate. And that launched me on this kind of unfortunate adventure to push back against some of the what arguably is misinformation, disinformation was spread by some of the people who were creating policy at the time and are still creating policy. And until such time as we change the people that are making bad decisions to people that know how to provide the precautionary principle, and understand airborne transmission, asymptomatic transmission, long COVID, are willing to speak these things out loud, I think we're going to continue to be in a lot of trouble. So anyways, that's my preamble. Over the years, I got involved in a lot of just grassroots volunteer organizing. I was involved in Mass for Canada, Protect Our Province, Alberta. And for a long time, we were like, okay, well, we should have a national organization because, this is a big problem. And then, in our mind, we're like, well, this is the 4th wave. It's going to be the last wave, right? And then, oh, it's the 5th wave. It's going to be the last wave. Well, I think we just completed the 10th wave, and maybe that was the last wave, but there's still a lot of work to be done. Even if that's the last wave, we still need to work on making schools safer, making other public shared spaces better air quality. We need to work on supporting those with long COVID, and even if there is no more COVID, there's still measles and other and future pandemics that we need to be prepared for, because obviously we were not prepared for this one. So that's my other intro to the Canadian COVID Society, which was just launched less than a week ago. There's a very small board of just 5 of us that are working on this. We just wanted to keep it tight because there's a lot of opinions out there in the volunteer world, and we're cross-national, we're multidisciplinary, but we're small and nimble at this point, and we're still trying to figure out what we're going to do with this organization. I think because there's so many people that want to work on this actively, that we'll be able to provide a bit of a structure for that, because we'll have hired staff. And it's amazing what you can do when you have somebody working 35, 40 hours a week on a specific task, rather than just having people work on the sides of the desk. So we want to be able to support the Canadian Airborne Transmission Coalition and Safe Schools Ontario and all the POPs across the country and all the other organizations that are doing amazing work for free. So maybe we can provide some of that funding, financial, but we're still working on it right now. Our main goal is to raise enough money to hire a staff. That takes time. I think we've got a few thousand in the bank now. We need at least, for a half-time person, probably 50,000 in the bank, full-time person, 100,000. So that's what we're working on now. And then things will evolve as we go. So if you want to reach out, we want to give us some money. Unfortunately, we're not a charity yet. It takes time to become a charity. We have already put in an application for that, but that'll take 3 months to a couple of years to get that status. But you can donate on our website. We're also starting to get information on volunteers, although we're not quite at the point yet where we can actively mobilize those volunteers. So that's it.
Thanks so much for your leadership, Joe, and great advocacy. Really appreciate your time here as well.
Anger and fear are powerful motivators.
So we're kind of moving on to the next speaker, Dr. Simon Smith. We have sort of said that we can probably go a lot longer than the hour and a half. So, but we might just hand you over to Simon, and then after Simon, Dorothy Wigmore will present the next session. So over to you, Simon. Thanks.
Thank you very much. Thanks, Kevin. So I'll just share screen and try and see what I can see. Thank you very much. My background, I'll just add in, is from a career in design and development of respirator filters with a Canadian company through in Canada. I retired from that about 4.5 years ago, but since the mid-2000s, I've been involved with development of standards, both in Canada for the CSA group and internationally for the International Organization for Standardization. So I talk a bit about the recent work now that's been undertaken over the COVID period and currently with CSA standards that are relevant to respiratory protection. And just to mention, in case anybody wasn't aware, we have in every province and territory and federally health and safety legislation that governs governs workplaces, and these regulations lay out the bare bones. And when it comes to implementing what's needed in workplaces in terms of how to select and how to use proper respiratory protective equipment, they generally cite the Canadian standard for selection, use and care of respirators. That is either a legal requirement in some provinces and federally, or it is considered a best practice. And employers are required, if necessary, to provide respiratory protective devices, and these have to be approved by an agency, and the one that Canada has used for the last 50 years is the US National Occupational Institute Institute for Occupational Health and Safety, NIOSH. And you hear about NIOSH approvals, and NIOSH equipment relates to that organization that has conducted approvals. That was really established because back in the early days of setting up this legislation in the 70s, there were only American providers into Canada, and so it made sense to use that. When it comes to setting standards, there's a federal agency called the Standards Council of Canada that supports standards development in Canada and authorizes various organizations to set standards. And the CSA group, which is Canadian Standards Association, is one of these organizations, and its area of coverage is occupational health and safety, except in clothing, but it deals with the respiratory side. And they have two branches, one that deals with standard setting and the organization of the process for that, and then the other is product testing. So they maintain laboratories and facilities for doing that. And people will be familiar with CSA approvals on things, electrical goods and safety boot shoes and things like that. So they cover a variety of areas. Just to mention that the organization Health Canada, under the federal government, approves medical equipment, and that does include surgical masks. But I hope everybody is aware that a surgical mask is not considered to be respiratory protection because of the very poor fit to the face of most designs. With respect to the standards that CSA provides, there is a range. There are two of interest when it comes to discussion of the pandemic. The one for selection, use and care of respirators that's been around for about 40 years. And then a new one that was developed during the pandemic, and I'll just explain why in a minute, on the performance of filtering respirators. And that came out very quickly as it was very necessary. And some standards, as you see, are covering selection and usage and guiding how to use products, and others set the requirements for how products must work. And in an automotive comparison, it's like one set of standards saying how a car manufacturer must design and install the seatbelt, and the other type is saying that you should wear a seatbelt. So there's these two differences in guidance and performance. So there are some others in Canada, but I'm not going to cover those, but you can search the CSA website and learn more about those standards too. So first of all, during the pandemic, what was happening? At the start, I think everybody can remember there were issues of respirator shortages in healthcare. We had concerning situations. Alec had mentioned stockpiling, and then that had been largely discontinued, and they were even destroying stocks during the first few months of the pandemic. That was still going on. Canada did not have any national manufacturers either. There's a company making respiratory protection products, but they were not the filtering facepiece type that people were seeking during that time. And we also had problems with importation. There was the stability of external supplies into Canada was concerning, and so action had to be taken fairly fast. A number of manufacturers came forward and said we can either establish new operations or adapt their existing equipment to make these kind of appropriate respirators. But again, because of the legal requirements, they needed NIOSH approval. That's how it's been for a long time. And NIOSH itself, with its focus on US needs, changed its prioritization so that these same companies could not get prioritization, could not get prioritized for approval, couldn't get their products approved in months, the situation we faced. Health Canada stepped in very quickly and allowed other kinds of respirators to be used with other standards, not just the NIOSH ones. And then they did issue early on a specification that set requirements for how respirators should be used. And that sort of filled the gap as these companies could now go through that route. But the long-term solution was for the CSA to set a new national performance standard for respirators. And that was undertaken very quickly in under a year in 2021. And a number of people on this call were involved in that, and it was a very exciting piece of work to be involved in, and it has met that need. So we now have a Canadian certification system that works in parallel with NIOSH, providing a channel for manufacturers to get product into healthcare where it's needed. The long-term need also is for the selection standard to incorporate those new types of approved respirators, and also to be updated, although we just published it in 2018, to accommodate factors that had arisen due to COVID epidemic, and where we need to take in some learnings from that. There is a process for doing this. It's very, very standardized. So CSA actually, as mentioned, both conduct standards development and product certification. There's continuous review of standards, and you'll see standards date changes every 5 to 10 years. There's a new version of a standard coming out if it's a CSA standard, and this is all decided by committee. These committees have a structure that is very organized, the representatives from the manufacturers, labor unions, users of standards, test laboratories, regulatory agencies, consultants, and so on, and in a balanced way that no one group can predominate. And these committees meet. Historically, it was fairly relaxed every few months, and standards were gradually worked on with Zoom and other facilities. We can now do that much faster. We may bring in experts as well to assist with the deliberations, and that certainly happened during the development of the update to the selection standard and during the performance standard update. And you see there are various stages there, either starting new with a seed document or existing versions with public input that's come in over time. There's review of all that input, drafts created, goes out for public comment, and we're at that stage now with the selection standard. Those comments are analysed, and then a finalised version is produced that goes to a vote of the committee members, and then the standard is published. And that, as I said, then it goes through around the cycle again as things change over time. It will again go through the review process and be updated again. So that's how these standard systems work. Current interest, as I mentioned, we had this very urgent work on a new performance standard, and CSA also set up a test facility for enabling companies to submit product to them and have it them approved. And the long-term standard on selection, use, and care of respirators is now being updated as well. Committees have met over 2023, and it's now at the public comment stage. So we're kind of getting towards the end, and it should be published mid-year. What the standard covers, in case people weren't aware, it's any kind of equipment from the disposable face pieces through to self-contained breathing apparatus. It supports the legislation, as mentioned, and the factors that come into it are how to set up and manage respiratory protection programs, medical clearance needed for wearers, hazard and risk assessment as necessary, selection guidance for the protection level needed, fit testing, and we know that's becoming very important in appropriate respirator use. And then other factors in usage are cleaning, inspection, and maintenance, and the qualifications of people involved in the process as well. A couple of things really of interest about this standard. It was the first in the world to come up with a selection guidance method for biological aerosols. Chemicals have been established for a long time, and that's very, very widely used, but this could establish a new method using controlled banding for evaluating the kinds of respirators you needed for different situations involving biological exposures. And that again was developed post-SARS using a lot of the same thinking that Alex mentioned from the SARS Commission. But unfortunately, although it was developed with a pandemic in mind, the standard has been minimally referenced during this pandemic. You don't see it in guidance from government or medical organizations, and at best it's been used minimally, sometimes cherry-picked pieces out of it, but never the whole thing used. And so that is something that the update wishes to address. We did have working groups. I won't go into these, just to say that we've looked at various areas of urgent need, biological aerosols, diversity needs in serving underserved populations that don't normally get sort of good service from the regulatory agencies, and fit testing of respirators, as there's been some changes in technology there. And then two workhorse committees looking at the editing of the standard and bringing in latest thinking into the standard itself. We also met during the year with outside experts, physicians, nurses, hospital workers, experts in biological aerosols and control banding, and a team from Quebec agency that have been doing some work in this area also. And we'll be meeting with ventilation experts in the future to make sure, again, we get good input into the standard. What's being changed, and you can go to a website, I'll show at the end, where you can look at this draft and provide comments. The key areas that fit testing is being updated to look at a new abbreviated fit testing protocol that's been produced in the US and provide a standardized form to make it easier to use. Looking at the barriers to accessibility of respirators, so new sections covering that. And looking at providing guidance for the healthcare community with a dedicated section. But in the future, we also want to bring out a parallel guide to further assist those in healthcare to use the standard. And then going on from there, looking for the specifics on selection. There are some changes needed generally because there's been some new types of respirator coming out, not only the CSA standard, new classes on powered air, and consideration of selection beyond just protection level. Things like exhalation valves, things like breathability, things like comfort and such that need to be brought into this situation, but had not been well addressed in the previous versions. When it comes to biological aerosols, we've looked very hard at the risk assessment method and updated that. Again, taking in some of the new thoughts around the fact that coughing and speaking can generate far more aerosol than the traditional aerosol generating procedures thought of in healthcare. And also brought into the selection guidance some changes again around consideration of ventilation and the controls needed, looking at going away from the biological laboratory kind of scale for assessing the level of hazard of a pathogen and making that slightly more detailed to assist in appropriate selection. Sometimes the biological lab scale did not match what the situation was in reality for hospital workers. So that's coming up. So these are in the standard. And this review is coming to an end shortly, but there's still time. There's a website there where you can look at the document. It'll look a bit like this, and you can comment on each section. And after that, it will be all the inputs will be reviewed, a final draft created, which will be circulated for ballot, and that should be published in the middle of the year. And then we'll start on that healthcare selection guidance after that to improve the ability of healthcare users not to be so afraid of the standard like it appears they may have been in the past. But ACSA does accept comments throughout the life of the standard and through that whole cycle as well. So some information there, and say thank you very much for that. Thank you. And I have to mention, I'm like many other people on this call, and there's great credit due to the very hard work of the volunteers over the course of this last year and previously in developing these standards. So thank you very much, everybody. Thank you.
And thank you so much to you, Dr. Simon Smith, for your great leadership and revising the standard. And I just want to ask people to actually look at the chat box. Dorothy just posted in the chat box a link to the standard app for public comment. Please look at it, and if you can, provide comment back. So thanks, Simon. We're kind of running out of time, but we did say we'd stay longer. You covered so much ground in such a short period of time. A lot of detail there, but really, really, really appreciate your time, Simon. Okay, over to you, Dorothy, to talk about the grassroots work. Thank you.
Yeah. So I know we're supposed to end at 2:30 Eastern, now daylight time. And we'd originally planned to have a half hour for snapshots from the grassroots. I think what I'd like to do is to see how well we can continue with this. We are recording. And I'm going to start by saying that we're trying to sort of go east to west on this. And for people who want to know more about these groups and others, we've actually got a directory that we've put together that I think someone may put the link in the chat, and we'll have it in on the website, and I'll put a link in the chat when we're finished this part of the event. So the first thing that I wanted to do was to start in Newfoundland with Keith Muse. Keith is a Stephenville, Newfoundland teacher and organizer for COVID Aware Canada. He caught the COVID awareness bug when his son was infected in 2021. He blends traditional advocacy with creative methods, like billboards, to encourage conversation. And since he wasn't sure about his schedule today, we're going to hear from him thanks to a video that he recorded yesterday.
Hey there, friends. So here we are 5 years into a once-in-a-lifetime pandemic, hopefully. And yeah, so down here in Newfoundland and Labrador, what we have been working on is just basically making as much noise as we can for COVID-19 and long COVID awareness. So we started out with some billboards and got, shook the hornet's nest kind of thing and got people to notice that, COVID was still around and that long COVID could happen to them. And we use that as our jumping off point to get people talking. So we also did a lot of work behind the scenes to ensure that our health authorities saw the advantage of having a healthy healthcare system. So they reinstalled masking in healthcare settings, and we were happy to see that first step, which is a great step in the right direction. And so from there, we are going to be working on convincing our education executives that healthy staff and students is really the way to go moving into the future, and that there is money to be saved when you spend some money on safety, like clean air, education programs, and of course universal masking in schools. So that's the kind of stuff we're going to be working on here in Newfoundland and Labrador, but we're also going to branch out and help anyone who wants to do it in their own provinces and really focus on human rights, inclusion, and basically just convincing those who are in charge that there is a benefit to keeping people safe and healthy. So that's our next moves that we're going to be making, and we're really proud to be doing that, and really proud to be working with everybody else all across Canada, all across the world, who are dedicated to bringing awareness to COVID-19, long COVID, and all of the different annoyances and damages that this terrible virus causes. So keep up the great work, everyone, and just keep pushing, because we got them on the ropes. They're ready to cave and go back to implementing strategies that really do well for society and for people in general. So keep pushing, everyone.
Thank you, Keith. So that's Newfoundland. There is a national group, although it's Ontario-based, that called CAVI, the Community Access to Ventilation Information. Kate Nyan is here from that group, and it wants everyone to be able to measure and improve indoor air quality. So they've been helping public libraries lend CO2 monitors and provide ventilation information. It's distributed these monitors to libraries in 7 provinces so far, and Kate has supported related grant applications in 2 US states. For information about how to reach them, it's on our little directory. Kate, where are you? Please.
Here I am.
Okay.
Thank you very much, Dorothy, and everyone with the Canadian Aerosol Transmission Coalition for organizing this event. I'm representing Community Access to Ventilation Information, CAVI. It's great to be able to share our work helping public libraries stand up CO2 monitor lending programs. So far, we've given out more than 300 CO2 monitors to 29 Canadian public libraries, including some whole province library systems. And 30% of the Canadian public can walk into their local public library, borrow a carbon dioxide monitor for free, and find out whether their spaces are ventilated sufficiently with outdoor air. So why is this important? As the United States Office of Science and Technology Policy put it, the most common way COVID-19 is transmitted from one person to another is through tiny airborne particles of virus hanging in indoor air for minutes or hours after an infected person has been there. That's why improving indoor air quality helps reduce COVID transmission. But most people don't have the tech to measure indoor air quality, and they don't know that it's important in the first place. So here's how library CO2 monitor lending can help. Because people exhale carbon dioxide, the difference between indoor and outdoor carbon dioxide can help you understand, are you getting enough fresh air in this indoor space? Or are you breathing in air and potentially infectious aerosols exhaled by the other people in your space? Now, carbon dioxide numbers are not a silver bullet. The CO2 readings don't account for the positive effect of air filters, for one thing, but it's still a valuable tool. And since libraries are trusted sources of information, they're embedded in communities, they're a great venue to increase access. So here is feedback from real library users who borrowed CO2 monitors from their public libraries. Someone in Nova Scotia said, I was surprised how poor the ventilation is in our apartment and how quickly opening the windows or turning on the kitchen hood vent can make a difference. And someone from Ontario said, I was so pleased to be able to borrow the Aeronet. It helped me identify the fact that the heat recovery ventilation in my home while running continuously was not actually working. With a little tinkering, I was able to discover that one of the vent dampers was stuck in the closed position. I corrected it, and CO2 levels are so much improved now. I'd never have known without the CO2 monitor. So when people can borrow a CO2 monitor from their public library, they are informed and empowered, and they can create safer environments, and they can engage in safer behaviors. Now, there are two questions people usually ask. First of all, does my library have CO2 monitors? Well, on our website, the CAVI website, we maintain a map of all the libraries with CO2 monitors that we know about. And then the next question is, can my library get free CO2 monitors from CAVI? And I hope so. This Canadian CO2 monitor expansion program is still running. You can visit our website to apply and ask your library or your community organization to apply too. We especially want to support remote or rural communities, First Nations, Métis, and Inuit communities, and French-speaking communities. Finally, I want to share another comment from another library patron. This person was in Alberta. Thank you to CAVI and Edmonton Public Library for making the loan possible. The Aranet is a terrific device, but the cost was prohibitive for us to purchase one on our own. In a more general way, I appreciate the idea of a program like this so much, namely that a public entity can provide a service to people who would otherwise not be able to access it, all at the behest of a committed group of volunteers who know their stuff. And that's true. Volunteers can make a difference. Community members can make a difference. You can make a difference, especially if you find partners to collaborate with. And on that note, I'd like to finish by recognizing our partners, CAVI's amazing intern, Shiven Taneja, CAVI supporters, the Balvi Foundation and Prescientex, and my co-founders at CAVI, Danielle Kane and Cheryl White. Thank you.
Thanks very much, Kate. And Danielle is a name I recognize. She had things to do with the coalition a little while back. So next, we are going to hear from Kathleen Gadd in New Brunswick. She's a health sciences librarian and mom from Miramichi who enjoys improving lives with knowledge translation. Whether it's building DIY air cleaners for home and community or delivering masks throughout the province with Protect Our Province, New Brunswick, Kathleen, her friends and family are always ready to make indoor air healthier and safer. Today, we have a little video she made about COVID precautions used in the medical office where her husband works. And she promises me she's going to include the word health in the introduction. Oops. In the
Improve patient and worker safety with curbside. My name is Kathleen Gadd, and I am a volunteer member of the Canadian Aerosol Transmission Coalition. This video will show you some of the health and safety solutions I've helped to implement in my family's office, where my husband is a healthcare worker. While these examples are in a healthcare setting, these interventions and more are an option in many different environments, such as offices, community centers, really any indoor place people gather. What you're seeing right now is a poster from the Ontario Society of Professional Engineers, which details their core recommendations for safer indoor air. What we've done in our office aligns very well with the OSPE recommendations. Today, I'm going to show you 4 interventions: ventilation, filtration, education, and respiratory protection. Starting with ventilation, when the pandemic started, we were in an office without mechanical ventilation. As you can see here, we moved to an office that does have mechanical ventilation. We monitored the ventilation using CO2 monitors to make sure that the system is working. There are other ways to increase ventilation, such as opening doors and windows, but we can't apply these methods to our exam rooms in a clinical setting. For more information about increasing your ventilation, see these websites. 2. Filtration. Our office has about 15 air cleaners, some purchased by other clinicians sharing the space too. Over 2 years, we've spent about $2,000 on ours. They paid for themselves the first time they stopped a chain of transmission of any illness. If the doctor is homesick, no patients can be seen, and the office does not make the money needed to pay the rent, the nurse's salary, other staff, and other overhead expenses. The annual cost of filters is about $600 for replacement HEPA filters. Purely from a return on investment perspective, filtration is worth it. 3. Education. As you can see in the OSPE recommendations, transparency and public education form an important part of safer indoor air. Here in our office, here's an example of a sticker in French talking about airborne transmission. And I've also placed a sticker advising people that COVID is airborne on top of one of the hand soap dispensers. This is a binder of information that I have in our waiting room, and there's another one just like it in our staff room. It contains government information and information from Engineers Canada in English and in French. Public health, our governments, medical societies, unions, all groups who care about health and safety have a huge opportunity. Almost no one in the public knows about aerosol transmission or how valuable clean indoor air and respirators are. We can make a huge difference in public health and safety. It's important that this information is in English and French and other languages used in your communities. I'm so glad about the Canadian COVID Society, which will help fill this gap. 4. Respiratory protection. Continuous universal masking is in place in our clinic. Child and adult-size respirators are provided for free to all patients and staff, along with information on respiratory protection. Thank you so much for your time and interest in how we keep patients and workers safer using aerosol science in our clinic. For more information, definitely check out the Canadian Aerosol Transmission Coalition, Occupational Health Clinics for Ontario Workers, or the Ontario Society of Professional Engineers. Thank you so much.
And thank you, Kathleen. We're going to zip over to Quebec next, to hear from Nancy Delagrave. She's been working on health and safety issues around indoor air for more than 10 years and on pandemic issues from the beginning. A physicist and mathematician, she's co-founder and scientific coordinator for the multidisciplinary group COVID Stop, and a vital part of the Aerosol Transmission Coalition since it started. Since 2021, Nancy has been working with long COVID patients and recently helped set up the Canadian COVID Society that you heard Joe talk about. She's the treasurer there. Nancy, où est toi?
I am here, Dorothy.
Ah, good.
Can you see her?
Yes, thank you. So COVID Stop's been really successful in reaching the media within Quebec, especially around ventilation at schools. And you even helped draft a bill to reduce respiratory infections in schools.
Right.
It was introduced in the National Assembly. At COVID Stop, what have you been doing lately and why?
Thank you, Dorothy. So what we've been doing is pretty much taking a step back and reflecting on our gains and our challenges. And we've decided that we would, join the forces nationally with a respectable, association like the Canadian COVID Society so we could be stronger and we could stop being ignored. I'm gonna give you a little story about COVID stuff. We started meeting formally in April 2020. In May 2020, we wrote many scientific articles about the necessity of masks and about airborne transmission. In May, we started formally asking for a mask mandate, which we were the first province to get in July 2020. In September 2020, we wrote many op-eds asking for CO2 meters in every classroom and air cleaners in every classroom. We were heard for the first part, working with the 3 opposition parties and meeting with the Ministère de l'Éducation. So we got the wired CO2 meters in every classroom in May 2020. But, and there's a problem, because the government very much controls the message. So even though the CO2 meters are wired, the public does not get raw data, or it is not shared in real time. What we have is averages, weekly averages, including the periods, the daily periods where the students are not there, and which brings the average down, and they are shared 3 months after the fact. And the Ministère de l'Éducation, they did not do the sensibilization campaign, the education campaign that they should have done to the parents and to the teachers. So in the last 2 years, ventilation in school is getting worse and worse because people think the pandemic is over. So they don't open the windows anymore. And they got many complaints, you know, that it was cold. Now measles is in Montreal. There's like 15 cases, and still they don't talk about ventilation. So that was one of our challenge. Another challenge that we had was the issue of air cleaners. They keep refusing them. Even last week, a parent got donated an air purifier, and she was told that they could not accept it because of COVID. They say it's dangerous. And so they pretty much live in opposite world, where we know for a fact that air cleaners reduce the number of outbreaks. They reduce the number of people who are affected, but they won't budge. And we've done everything we could. We did so many interviews. I think I've given 50 interviews on the subject. We did petition, etc. So we are at a stage where we think that it's, you know, a national endeavor, like Joe said, that needs staff and to have professional material that gives, I don't know, how can I put it, that looks really good and that we can bring to the Ministère de l'Éducation and the school administrator. And so this is why I've taken a step back, and we're very excited that la Société canadienne de la COVID est là. Merci, Dorothée.
Oh, merci, Nancy. And I'm sure the COVID stop will still be around, getting its fingers in the pie about various things.
For sure.
So we're going to skip a fair bit here because we wanted to hear from another of the pop groups. I know that there are folks I just discovered in Winnipeg, see the directory, and elsewhere on the prairies, and certainly in Alberta. But the last live interview we've got here, or conversation, is with Lynn Fietro. Lynn is actually Dr. Lynn Fietro, a retired Vancouver emergency physician. She spent most of her clinical career at the Vancouver General Hospital. And in fact, on March 7th, 2003, she was on duty when BC's first SARS-1 patient came to the hospital, to the emergency department. Their team's response won an award for its role in protecting the province from SARS. These days, Lynn is part of Protect Our Province BC, one of the many POP groups across the country, a grassroots group of physicians, nurses, health scientists, communication consultants, and community advocates. Like other POP groups, their goal is to help people stay healthy by sharing accurate information about the ongoing pandemic in BC and advocate for science-based policies using a multi-layered approach. Lynn, where are you, please?
I'm here. Good.
So I got the two questions for you. What's one recent success for POP BC, and what's next for you folks? Fill us in.
Yeah, so recent success, I think, was the briefing that we had on February 21st on COVID in your heart. It was with cardiologist in Edmonton, Leslie Kaza, and really highlighted how much how many more patients cardiologists are seeing because of COVID's harm on the heart and cardiovascular as well as neurovascular system. So COVID, as we know, is a vascular disease. And so really one of the strategy at POP BC is making the invisible visible and really showing the impact that lasts way after 30 days post-infection or reinfection. So on March 20th, we will have long COVID in children. It's a bit telling that we had to go outside of Canada to find a speaker. We were unable to find a speaker in Canada because there is so much minimization and really denial that children get long COVID. In terms of going forward, a little bit of regrouping. You know, I think Wendy in the chat, Wendy Green, hit it on the head. We are at a time of cognitive dissonance where here we're speaking to the converted, we're in an echo chamber, but how do we reach people that really continue to deny what is happening to our health, to our population in terms of disability and excess deaths because of COVID's long-term impact? And so how do we reach people? And as you know, Dorothy, we've been thinking a little bit more about how do we make people care? Because there's no information deficit here. What we have is an inability to get the message in. And so keep doing the same thing will only give us the same result. So how do we reach people based on what they care about and what matters to them? So that's one of the trains of thought. The other one is continuing with making the invisible visible. We're in a different phase of the pandemic where we are seeing the accumulation of chronic health disease, long COVID disability, and excess deaths that keep happening. And yet our public health officers across the country, and I'm a little bit more sanguine than Tara here, I think some of this is intentional, is basically stops counting after 30 days, the harms of COVID. And as Gosia showed, the iceberg image that was created by Dr. Anne Bérard and myself for Long COVID Web was to show how much is under the water and how much is going to impact the health of everybody who lives in Canada, our economy, society writ large, and also our future because of our children's impact. And so we think that we need to keep focusing on highlighting long COVID, long-term impacts, and really in 2024, we need to shift to a new definition of what is severe COVID. A child who develops diabetes after a COVID infection, that is a severe outcome. A 20-year-old who cannot go to law school anymore and has to stop her studies because she's bedbound, that is a severe outcome. And clearly there's no more public health in BC, and I don't think there's any more public health in Canada. If public health is about the 3 Ps, promoting wellness, protecting health, and preventing disability and chronic disease. That's not happening when it comes to COVID in Canada. And we need to do better. And somehow I think we need to leverage election year. There's election coming up in BC, and clean air has to be on the ballot. So that's where we're pivoting.
You've got a lot on your plate, Lynn.
Mm-hmm.
And I noticed that you mentioned earlier that you used you followed Keith's example with a billboard. So a nice tie-in from at least coast to coast. We need to know more about other groups that are doing this kind of thing. And so Kathleen and I worked on a little directory with help from Lynn and some others. I'm sure that we've missed some, but take a look at it. There's links to it in the chat, and we'll be putting it up on the website soon. It'll be hopefully a living document. So just to finish off this section, we wanted to end with something a little bit different and a little bit of fun, because there's lots of serious stuff here. But Jeff Berner, I actually know about from seeing him at a folk festival or two. He's a BC musician, accordion player, and he and some friends have put together a wonderful little video narrated by a song about building one of those DIY air cleaners known as Corsi Rosenthal boxes. So I'm going to share my screen yet again. This is the last time. And find, where has he gone to here? Just a second. Just a second. Let me just see if I can try it now. Sorry, the sharing is doing something weird here. So I'm going to try again. Here we go. So this is available on YouTube.
It's time to clear the air, 'cause COVID is still there. And if you want a cheap machine that will cancel toxic pathogens in the air, well then you ought to hear about the Corsi Rosenthal box. First you get your fan, keep the box that it came in. You'll need it for the floor. Now get filters, count them 4. What rating? MERV 13. The hardware store will know what you mean. Of course you'd be a schmuck if you don't have tape of duck. Now add a box cutter, you're on your way to warding off the pox. This is everything you need to build a Corsi Rosenthal box. With the filters, build the shell. In order to build it well, look for the big arrow. It shows how the air should flow. First filter you begin with the arrow pointing in. And build a filter fence by butting up against. Tape it up so every filter interlocks. Now you've got 4 strong walls for your Corsi Rosenthal box. Don't worry, there's not much more, but you've got to make a floor. That shouldn't come as a shock, since that's why you kept the box. So cut your square to fit, tape it on the top of it, turn it upside down, and then you're ready for the fan. Now with all you've done, you'll find that you're approximately 1 or 2 steps from done your Corsi Rosenthal box. Before you do the rest, you've got to give the fan a test, 'cause you'll feel like such a jerk if it turns out not to work when you've used up all that tape to attach it to the crate and covered gaps and slits with tape and cardboard bits. Oh, not to complicate, just make a little slit in the tape so the cord can escape, or else the thing will never go. Make a little slit, then cut another bit. Also with the slit they fit opposite and overlap them. Now you're sealing soundly so. You're sure it's only through the filters air can blow. Also, they take out dust and pollen and smoke, which is good to know. Tape the corners of the fan just to increase the rate of flow. Oh, congratulations, you just built one of the building blocks for being safe to respire. Now sit back and admire your lovely little Corsi Rosenthal box.
I just want to give him credit. You can see there were a lot of people involved. And there's his. So, a serious topic. It's always good to find a fun way to talk about it. So, in terms, I see there are a variety of messages here, and I'm just wondering whether, to round things off, whether anyone has questions for the snapshots or anyone else who is here. And if not, we will. Tara, are you putting your hand up?
Yeah, sorry, I'm trying to find my reactions tab. I was going to say that we probably need to facilitate a session for it, but I would like to, or we would like to know what types of data needs different advocacy groups have, and the format and how, like, what types of information people need. Understanding that will help us to, for a lot of it, it may be available, some of it may not be, but it will help us to put it together in a way that's actually useful for others, and that is publicly available. So I'll just to let you know that we haven't scheduled anything yet, but to keep your ears open, and we will probably announce on Twitter and via various mechanisms when we have a session where different advocacy groups can come and talk about the types of data that they would like to have for their advocacy work. And we'll see if we can put that together.
Yeah, and I'm sure if you let us at the coalition know, we can share that on our email list, and
exactly.
Perhaps with the email list for the people who've signed up for this webinar. Just to let you know, this is this is the first of what we hope will be several webinars in the next little while, looking at different aspects of the pandemic and how to prevent people getting harmed by it. So if you have an idea or a suggestion, even if you aren't able to, don't know much about the topic, but it's something you want to learn about, we'd be pleased to hear from you. I'm going to put the I can't type. I'm going to ask someone else to type. My fingers are acting up today. Somebody else to put the Aerosol Transmission Coalition email in the chat. Let us know what would be helpful, or stories that you've got to tell. We've heard a few of them today. We skipped a lot. That's what the directory is for, is to give you a chance to get hold of or find out more about what groups are doing, whether it's the large groups like the COVID-19 resources, the national ones, or the coalition, or whether it's groups like Masks for East Van, a small group that we were asking to come today, but they weren't able to. And as I say, I've discovered there's actually a Masks for Winnipeg group. I've been desperately looking for a Manitoba group. So I'm sure that we've missed some, and we need to hear more, both about what people are doing and what questions you've got. And so on that note, unless there are questions for the audience, from the audience for anyone else, I think we will, as I say in my family, I'll wave.